She's going to talk to us about mucinous cystic neoplasms.
Okay. Can you guys see my slides?
We can. Looks great.
Okay. All right, great. Okay, thanks, Sarah. My name's Jenny. Some of you may know me from going to the symposium in March, and I'd encourage everybody who's on the call to try to make it. It's a great event for nurse practitioners, PAs, who work in HPV, and I've really enjoyed meeting some new colleagues. So today I'm going to talk about mucinous cystic neoplasms, an overview and case presentation, and hopefully I'll keep it interesting. So I have no disclosures. So my objectives today are just to provide an overview of pancreatic cystic lesions, define what exactly MCNs are, review the pathogenesis, incidence, and characteristics, and review case studies, radiologic features, when you should think MCN, and also talk about MCNs in men, which is a very rare event, but can happen. So when we think about cystic lesions in the pancreas, there's basically three categories. One are your serous cysts, which would be your macro and microcystic cystadenomas. Second would be benign, which are pseudocysts or just simple cysts of the pancreas. And then the third would be mucinous lesions. And this is where the MCNs fall in, and our main and branch duct IPMNs. And those are the ones that are really considered precancerous and the ones that most surveillance programs are following. Serous cysts we follow as well because they can invade other structures and they can cause obstructive symptoms, but they are not known to spread to other organs or to become cancer. And then the benign cysts might require management, like the pseudocysts could need drainage, endoscopic drainage, regular epithelial benign cysts of the pancreas. It's kind of hard to prove when they're totally benign. We usually wind up just following them anyhow. This is a good little graphic that kind of goes over what cysts we're following. So you have your serous cysts, which have that classic honeycomb appearance. They could be macrocystic, where they have one large component to them, or microcystic, where they have multiple tiny cysts kind of pushed together. And the way I describe this to my patients is that it's like a clump of grapes in your pancreas. They can grow to be quite large. Sometimes I have one patient I'm following whose serous cyst is about 10 centimeters, not causing any symptoms, been there for about 15 years. But we watch it because they can grow into the colon and cause a perforation or obstruction. You have your two types of IPMNs, your main duct IPMN, which of course are more worrisome and generally are always resected. They can affect a part of the pancreatic duct or the entire duct, in which case the patient would likely need a total pancreatectomy. And then you have your side branch IPMNs, which are most of us who are doing the pancreatic cyst surveillance programs are keeping an eye on. Those tend to be multifocal and can, like in this diagram, shows communication to the pancreatic duct. And then out in the tail, you have pseudocyst, and those usually follow either an endoscopic procedure where the patient developed pancreatitis or a flare of pancreatitis on its own. That's a known complication of pancreatitis, which Sarah's going to talk to us about later on. So MCNs. Up until, I think it was the late 90s or early 2000s, the World Health Organization characterized MCNs as a separate entity, which are different than other pancreatic cysts, such as IPMNs. And they're characterized by columnar mucin producing epithelium, which is supported by ovarian stroma. So that's very important because that's kind of the caveat, the telltale sign that something is an MCN. It's very hard to prove that on biopsy. You mostly just get that on your pathological staging. And for that reason is why they almost exclusively occur in women. They are considered to be pre-malignant and have a moderate malignant potential according to most of the guidelines. Current guidelines, most of them, recommend resection if you suspect that it's MCN. The thing that's good about an MCN is that when you take it out, they normally don't come back, so you don't have to follow the patient for forever, unlike you do with resected IPMNs. But lesions with an invasive component, because they are precursor lesions, and some of them can have high-grade dysplasia or frank cancers, they can recur, and that's similar to pancreas cancer. So what's similar and different about IPMN and MCN? So common features, both secrete mucin. So you'll see that on a EUS-FNA of an IPMN or an MCN. Cystoid CEA tends to be elevated, greater than 200, and they're both considered precancerous. But what makes them different? MCN is usually isolated, it's usually one cyst, whereas IPMN can be one cyst or it can be multiple cysts, which many of my patients are multifocal branch duct IPMN. IPMN is known to communicate with the pancreatic duct, whereas MCN is not. Most guidelines suggest observation for IPMN and resection for MCN. So if your clinical suspicion based on the radiographical features is that it's MCN, most of the guidelines suggest resection. And MCN tends to be localized to the body and tail, whereas IPMN can happen really anywhere in the pancreas. So I went through the guidelines, and actually there's a great summary that was just published August 2019 in the World Journal of Gastroenterology. They basically went through 5 sets of guidelines. The European guidelines that were just published recently went over the TANACA guidelines that were updated, the AGA guidelines, which are the bane of my existence because they say to stop following after 5 years, and the ACR recommendations. And basically in all of those guidelines, they lump IPMN and MCN into the same category, except the European guidelines. European guidelines suggest that for lesions up to 3 centimeters, even if you suggest that it's an MCN, if you think it's an MCN, you could observe it, whereas the other guidelines recommend straight up resection for MCN. So that's one difference that I found in looking at the guidelines. I'd say our bias here is to definitely resect if it's suspected MCN. So just a few case studies. So this is the first one, 64-year-old female, history of Hep C, came from a blood transfusion years ago, treated with Harvoni and cured, and on imaging for her liver, they found a lung mass, a mediastinal mass, and a large pancreatic cystic lesion. So she went on to have the lung and mediastinal masses resected. Those wound up being a T2 lung cancer and a thymoma. NED from both of those, and then they directed their attention to the pancreas. And this is why I showed this one. This is a fairly large MCN. You can see here, I don't know if there we go. Calcifications here at the bottom of the cyst, as well as a thickened wall. This is fairly classic for MCN, actually, but this one is on the larger side. She went on to have distal pancreatectomy, splenectomy, pathology showing MCN. No lymph nodes were involved, which they wouldn't be involved if they're low-grade lesions, only if you had an invasive component. And here is her post-op scan, which we switched to MRI to prevent her from having to have radiation. You can see her pancreatic remnant here with a normal pancreatic duct, and everything kind of filled in where the cyst was. So here's an interesting study number 2. This was my patient, 56-year-old female, which I feel like all my patients get scans for hematuria, which is how we find their cysts. And she was followed with a short interval scan, which is according to guidelines, and then transitioned to me for surveillance. So this is 2015. You could see there's this cyst right here. It doesn't really look all that concerning. It wasn't even that big. I think it's about a centimeter or so. And this was after a short interval scan, so then we went to yearly, and then you pop over here and see that it grew. So this one kind of fooled us a bit, because when it grew like this, we said, oh wow, that kind of looks like an MCN. We should EUS it. So we did, and her serum, the cystoid CEA was only 8, but there was mucin on cytology. Anyway, we weren't convinced that it needed to be resected right away, but we did another scan shortly after that, and that's what she had at that point. clearly enlarging unilocular cyst in the tail of the pancreas. So we decided that she needed to have resection. One thing I want to point out about this is a classic appearance for MCN because it's a well-circumscribed lesion. Looks like a perfect circle, and it's displaying the rest of the pancreas like this. This is called the golf tee sign because it kind of looks like the cyst is just sitting in the rest of the pancreas like a golf tee, and that's very classic for MCN. She underwent distal pancreatectomy, splenectomy. It was 2 centimeters by 2 centimeters, low-grade MCN. And on the pathology, they went back and did give an addendum saying that they did see the ovarian-type stroma, which was positive for progesterone receptors, supporting the diagnosis of MCN. Postoperatively, she did well. She had a small pancreatic fistula managed with the drain, no evidence of cyst on follow-up scan, and then we discharged her from follow-up. This is our third case that I wanted to show you, and actually this patient is coming to see us on Monday for consent and to talk about what we should do. So this lady had a scan for unrelated reasons last year, and again had this tiny cyst here in the pancreas. I mean, if I just looked at that, I would think, oh, that's probably an IPMN. There's no pancreatic ductal dilatation. The rest of her pancreas looks normal, and this was her short interval scan from a previous institution, so she had then been recommended to come back in a year. And this is her now, a year later, and clearly enlarged. And again, you see the same characteristics. Large unilocular cyst with the golf tee sign. She had at US last week. Her CEA was 29,000, high amylase and mucin, and a suspect MCN. So just wanted to touch on briefly MCNs in males. This comes up in our TMT all the time, like can men get MCNs? So I had the research coordinator query our database of resected patients, and she pulled 122 resected MCNs in the last, I think, like 15 years based on pathological diagnosis. Out of those 122, 119 were females, 3 males flagged for possible MCN, but on further review, really only one of them was a true MCN, which was actually interesting because it was an MCN with an invasive carcinoma, and it was arising from the bile duct. It was actually even hard to see it on the scan. So it was not typical in 2 ways. 1, because it was in a man, and 2, because it was in the head of the pancreas. He had a Whipple last October. He's doing well. I have his scan here. You can kind of see right here, this shadow within the bile duct. That's actually where the invasive component was coming from. There is a study from Japan published last year, 2017. It's 2 case studies of men with MCN aged 55 and 71. Both went on to have resections and were pathologically confirmed. They described up until that point, they had seen MCN reported in the literature in 12 patients up until then. So it is very rare. It can happen. And we should not keep it off of the differential. If the radiology features look like MCN, you should keep it in the back of your mind. So just some summaries, recommendations. MCN should be considered in a patient with a single pancreatic cyst, mostly located in the body and tail. They can grow relatively quickly, which could tip you off that it is an MCN, and it's important for anybody working in surveillance, cyst surveillance programs. They tend to have the high CEA like the IPMNs, but not always, so don't get fooled like we were with that lady. And they're more common in men since they're derived from the ovarian stroma, but they can occur in males, so keep it within the within the differential when you're working up these patients. I will say I did also find another case report of a MCN diagnosed in a transgender woman who became a man, and they were trying to see if that had anything to do with the hormone therapies that she had been on, or he had been on. So that's basically all I have about MCNs. I kind of like these because once you take them out, you don't really have to do much. You know, just get another scan and then we don't really follow them. So they're a little bit easier than the MCNs than the IPMNs that require lifelong surveillance. My references, and I'll hand it back to Sarah.
Thanks, Jenny. That was a really great overview of the cystic lesions we see of the pancreas. I'm going to switch gears a little bit here to talk about autoimmune pancreatitis. Bear with me.
Can I ask a question while you load that? Is that okay?
Oh, yeah, of course.
This is Elise Diner. I work in at St. Vincent in Los Angeles. I just had a question. Thank you for that presentation. I just wanted to ask, and I didn't have access to the slides, so maybe I missed it, but just about the role of, you know, what surveillance modalities you use in that situation. Like, is there a role for, you know, imaging with an MRI, MRCP, and then alternating with the US? Like, what suggestion do you have for that?
So for MCNs, I mean, most of the guidelines recommend that MCNs get resected, like I said, except for the European one. But for IPMNs, we typically just use MRI or CT. We don't alternate with EUS in our practice. I know some guidelines suggest that, but we don't do that.
Got it. And do you just do like a triple phase CT with pancreas protocol, that type of thing?
Yep. So if you're monitoring IPMNs and you're going to do lifelong surveillance, the MRCP is the benefit of that is there's no radiation, right? But there's some patients are concerned now about gadolinium, or some people just cannot do an MRI. So in that case, we do either a CT angio of the pancreas, or we have another protocol here, just a CT pancreas cyst protocol, which is a very limited view of just the pancreas. But any pancreatic protocol CT would give you the information that you need. And they're equal in what they're going to, you know, monitor. The quality is equal. It's just a different modality.
Okay. Thank you.
Yeah. And the reason why we don't do EUS on every patient, I mean, there's like massive debates about this at the AHPBA, I feel like every year.
Yeah, right.
We don't do EUS on every patient because it's not going to change the way we're going to manage the patient unless there's something concerning. And sometimes EUS can give you a false positive. We've had that happen where patients go get an EUS somewhere else and the pathologist will call like a minute focus of adenocarcinoma, and then you're kind of stuck with that diagnosis looming, and it just increases the surveillance that you have to do. And it also makes it really hard for the patient, because if you think that, you know, your pathologist reads it and it says, no, it's not a cancer, then the patient's, you know, completely anxious, appropriately so. But so that's why we hold off on EUS. We use it more to prevent people from going into the OR than to get people into the OR.
Got it. Thank you. I appreciate it.
Sure.
Any other questions before we move on? Nope. Okay. So I'm going to switch gears, and I'm going to start with a case presentation. So this is a patient RB, a 60-year-old gentleman who went to his primary care provider a couple years ago with back pain, 40-pound weight loss, new onset diabetes, past medical history significant for hypothyroidism, hypertension, reflux, sleep apnea, arthritis, and a heart murmur. He had no prior operations, occasionally drank alcohol, and a 10-year history of tobacco use that he quit in the 90s. Family history, as you see here, brother with prostate cancer, sister with bone cancer, presumably multiple myeloma, and a sister with breast cancer. So primary care drew some blood work. Bilirubin was normal, but he did have an elevated ALK phos and about 1,000. Transaminitis at AST 566 and ALT 728, uncontrolled diabetes, A1C of 13.1, and an elevated tumor marker of CA19-9 of 1,120. This prompted a CT scan at the outside hospital that demonstrated 2-centimeter area fullness in the pancreatic head, some mild intrahepatic biliary dilatation, and abrupt cutoff of the CBD at the pancreatic head. After seeing this CT scan, he had an endoscopic ultrasound, again at the outside hospital, demonstrating a 3.5-centimeter mass in the pancreatic head that appeared suspicious for adenocarcinoma. There was abutment of the SMA, portal vein, SNV, suggestion of a biliary stricture, and some associated atrophy. The pancreatic duct did not appear dilated, and there were no concerning lymph nodes. A biopsy was obtained and was inconclusive for malignancy. So primary care did draw IgG levels, but these were the immunoglobulin levels, not the serum subclasses. We requested that they draw the serum subclasses, and per a telephone note, they were drawn in normal. However, I could not find the primary data on my review. So at Duke, we got another CT scan, pancreas protocol CT of the chest, abdomen, pelvis, similar findings, this ill-defined pancreatic head mass, abutment of the portal vein and SMV without distortion, expected pneumobilia after a stent, some non-specific mediastinal nodes and parapancreatic nodes, tiny lung nodules, and the pancreatic duct was not dilated. So I want to try out some audience participation. So again, we have a 60-year-old gentleman, weight loss, new onset diabetes, suspicious pancreatic head mass, inconclusive pathology. Jill is going to provide some information on the screen. If you guys could get your cell phones out and vote as to what you would do the next step, that would be.
Okay, so if everybody just wants to type in www.menti.com, as soon as that browser pulls up on your cell phone, enter the code 291136 and cast your vote.
I realize that some of you may be driving and calling in or not able to vote on your cell phone, but I wanted to give the audience participation a try. So it looks like here more folks are voting for the repeat endoscopy. So I'll go to the next slide. So this patient did indeed have repeat EUS and ERCP, similar findings. The 3.5 centimeter mass, malignant appearing pancreatic ductal and biliary strictures, suspicious for adenocarcinoma. And this time pathology was atypical and inconclusive, but there were some IgG4 stain and scattered plasma cells. Due to crush artifact, there were not more than 10 plasma cells, and there were less than 40% of plasma cells positive for IgG4. So this was felt to be inconclusive for autoimmune pancreatitis, and the brushings were benign. So again, I'd like you guys to vote again. We have another biopsy that's inconclusive. What would you do here? Send this patient for another biopsy, get another imaging study, or recommend a Whipple procedure. And Jill will provide the information on the screen again. Looks like we're split across the board, but more people are voting for repeat imaging. I'll go to the next slide. So we recommended that this patient proceed with a Whipple. And I have the pathology here. You'll notice I've highlighted a few of the buzzwords, if you will. But this patient, the pathology demonstrated a severe inflammatory and fibrosing process, destroying much of the parenchyma, large numbers of lymphocytes and plasma cells with eosinophils, this prominent periductal accentuation without neutrophils within the ducts, focal venulitis, and obliterative phlebitis, no neoplastic process, and there was a marked increase in the IgG4 positive plasma cells, with some areas more than 100 IgG4 positive cells per high power field. This had an extensive interdisciplinary review, multiple pathologists reviewed, and felt that this was suggestive of autoimmune pancreatitis. So the International Association of Pancreatology defines this disease by a heterogeneous disorder characterized by obstructive jaundice, with or without pancreatic mass, histologically by lymphoplasmacytic infiltrate and fibrosis, and importantly, therapeutically by dramatic response to steroids. There are two main types of autoimmune pancreatitis: type 1, or lymphoplasmacytic sclerosing pancreatitis, LPSP, or autoimmune pancreatitis without gels. And then there's type 2, really a distinct entity, this idiopathic duct-centric pancreatitis, or IDCP, also known as AIP with gels. For purposes of the rest of the presentation, I will refer to them as LPSP or IDCP just to highlight the difference between the two. And I want to stress that this can be a really challenging diagnosis. It can mimic pancreatic cancer, which we all know is a very aggressive disease and something that we don't want to miss or delay the diagnosis. Here's just a broad overview of the differences between the type 1 and type 2, or the LPSP and IDCP. The LPSP is more common, and it's also more common in men. Typically impacts older patients around the age of 60, and there's often other organ involvement or extrapancreatic involvement. The serum AGP may be positive in these patients, and about 3/4 of patients present with obstructive jaundice. These patients are much more likely to have a relapse. The IDCP does not have a gender predominance, typically affects younger patients around the age of 40. 30% of patients will have inflammatory bowel disease, most often ulcerative colitis. There's little to no IgG4 positive plasma cells, and the serum IgG4 is typically negative. Because of this, you often need histology to diagnose. Just to make things even more confusing, the LPSP can be seronegative, and the IgG4 can be falsely positive. So on a prior slide, I mentioned that it was either autoimmune pancreatitis with or without gel. So what exactly is this gel? It's a granulocyte epithelial lesion. It's essentially duct-centric neutrophilic infiltrate and associated with ductal destruction. So there are these interluminal and intraepithelial neutrophils in the medium and small ducts that lead to the destruction and obliteration of the duct lumen. They can be very abundant and even lead to little microabscesses, and this is really the hallmark of the IDCP. There is some crossover and pathology characteristics between the IDCP and LPSP, specifically the lymphoplasmacytic infiltrate and the storiform fibrosis. So how do these patients present? Typically obstructive jaundice, sometimes or oftentimes with a pancreatic mass. It is not common for patients to have significant weight loss, to have pain that requires opioids, and to have a dilated duct. That being said, the case I presented, the patient had significant weight loss. Pancreatitis, either biochemically or radiographically, is common, but these patients are not often symptomatic. This is often an asymptomatic presentation. And acute recurrent pancreatitis is more common with the IDCP. I mentioned that there's this other organ involvement in the LPSP. This is most commonly involving the biliary system. 80% of patients will have an IgG4-associated cholangitis, but it can also affect a multitude of other organ systems. Patients can have orbital pseudotumor, involvement of the salivary glands, pulmonary interstitial fibrosis, tubular interstitial nephritis, retroperitoneal or mediastinal fibrosis. I know when I was in the outpatient setting, we not infrequently got referrals for concern of retroperitoneal fibrosis and needing a larger biopsy. But half of these patients will have pancreas-only involvement. And of course, this can coexist with pancreatic cancer, so it really always has to be on our radar. So what do the imaging studies look like for these patients? I think we most often hear the sausage-shaped pancreas. This is a diffusely enlarged pancreas where there's loss of the lobular contour. Patients can have a focal mass. If that occurs, it's most commonly in the head. And atrophy is not common. If it does occur, these are typically patients with late-stage disease or that have prior treatment. Capsule rim is very characteristic for the autoimmune pancreatitis. This is hypo-enhancing in contrast to the hyper-enhancing rim of malignancy. And that's because this is really a pancreatic inflammation as opposed to compression from a malignancy. When we see these either pancreatic or biliary ductal strictures are often multifocal, and calcifications and cysts may be present in a small percentage of patients. When patients have kidney lesions, they're typically multifocal, bilateral, and again, that retroperitoneal fibrosis can occur. So here are just 3 examples that I found in the literature of this sausage-shaped pancreas that you can see in A and B, that just diffusely enlarged pancreas. And then C does show a more focal mass-like presentation. This is actually, these are images from a patient that was discussed in our multidisciplinary conference last week. So 49-year-old female presented with new onset diabetes, 30-pound weight loss, and obstructive jaundice, which are always on our minds cancer proven otherwise. Interestingly, on her ERCP, she had 2 benign apparent stenoses, 12 millimeter in length, and also had an ampullary biopsy that demonstrated a granuloma, raising the question of IBD. But on her imaging, you can see that really nice kind of, diffusely enlarged pancreas. On ERCP, typically most of the pancreatic duct is abnormal. Often it's more than 2/3 of the pancreatic duct. And again, when they have these strictures, they're typically long strictures. So in contrast to cancer, longer strictures in the ductal location is less. This is actually that patient's ERCP as well. So how do we diagnose autoimmune pancreatitis? Again, this is really challenging. We always need to work up cancer, kind of cancer until proven otherwise. There are numerous guidelines. I'm just going to briefly highlight 2 of them because they can be a little bit confusing, but I'll talk about the HISOR and the ICDC. So this is a set of guidelines that came out from the Mayo group, and it's highlighting these 5 cardinal features of histology, imaging, serology, other organ involvement, and response to therapy. These words probably sound familiar by now: this lymphoplasmacytic infiltrate, obliterative phlebitis, fibrosis in the storiform pattern, and then the infiltration of the IgG4 plasma cells, more than 40% of the total IgG. Imaging, again, sausage-shaped pancreas, longer multiple strictures without dilatation. Serology, elevated IgG4. This is referencing a more than 2 times the upper limit of normal, and we often see mild elevations. Other organ involvement, again, and then response to therapy. I think this is just a nice table reviewing those guidelines, and especially in the bottom here, we can diagnose based on these criteria if we have the histology, if we have imaging and serology, or the strong clinical suspicion and a response to therapy. Similarly, here's the ICDC. This is from the International Association of Pancreatology. Very similar 5 features. You can see it gets a little bit complicated here with level 1 and level 2. I won't go through it in detail, but I thought it was nice to have for reference. This is a nice example of the pathology findings. Both A and B here show this lymphoplasmacytic infiltrate. C has the storiform fibrosis, obliterative phlebitis in D. The IgG4 infiltration is highlighted at E, and then there's the gel lastly in F. I wanted to briefly talk about the serum IgG4. I feel like this is something that we often check, and it's not always as helpful as we want it to be. It certainly has its pitfalls, but it can be very helpful. It has a sensitivity between 67 and 94%, and a specificity of 89 to 100%. Just a reminder, the sensitivity is the true positive in our ability to detect the disease, and the sensitivity is the true negative. This has a low positive predictive value. We have a lot of false positives when we check this. It can be positive in cancer. So 7 and 10% of pancreatic cancer, more than 10% of cholangiocarcinoma. And again, when ordering these, just be sure to order the serum IgG subclasses, which is, at least here, a send up to Mayo, comes back within 24 hours or so. So how do we treat these patients? Steroids are really first-line therapy. Typically 0.6 to 1 mg per kg per day. For a 70-kilogram patient, that's 40 milligrams a day. There's varying recommendations for beginning with anywhere from 2 to 4 weeks. Here we treat for 4 weeks and then reassess. When you truly have a diagnosis of autoimmune pancreatitis, this is typically very successful. If you do not have a response, then again, think about cancer. And also, it's important to remember if patients have either a falsely elevated IgG4 from malignancy or even a malignancy-associated pancreatitis, that can improve with steroids as well. Because of the other organ involvement, patients may often need biliary stents, management of exocrine insufficiency or diabetes. Spontaneous resolution can occur. And what's really important, the patients who have the IBCP or type 2 autoimmune pancreatitis The flares typically coincide with flares of their IBD, and so it's important to treat both of those. And of note, patients that have diabetes, some of them actually have improvement with steroid therapy. Patients can have relapse of this, especially the patients with a type 1 or LPSP. Up to 60% of those patients will relapse. For IBCP, it's a much lower rate. We can retreat those patients with steroids. I will say at Duke, if they fail, we typically refer them to rheumatology. There are other non-steroid therapies, such as rituximab, that can be used first line in some patients who just cannot get steroids, or if they have a high risk of relapse. And some of the higher risk features are either a proximal biliary stricture, or a really young patient, or high LPOS. There are also immunomodulators or immunotherapy that can be used. And I'm just going to end here on this treatment algorithm for reference. I think it just highlights nicely how you could approach treatment for a patient with autoimmune pancreatitis. On the screen left is an algorithm for the type 1 or LPSP. You'll note that both of them start with prednisone 40 milligrams a day for 4 weeks and reassessing the disease activity. If there's not a response, think about another diagnosis. The patients with the LPSP may need some maintenance therapy or additional steroids, and then you can see here that you can either treat with rituximab or the immunomodulators. And that's all I have, and if anyone has questions, I would be happy to take them. If there are no questions related to the presentation, if anyone has questions about upcoming webinars or the symposium or anything else that they want to mention, you can certainly do that now. And there will be emails coming from Jill for links, reminders about the upcoming deadlines, and then also this presentation that's been recorded.